Vitreos Health, Beyond Insights.
From day one, our approach has been to leverage clinically accepted, established, proven disease models that have widespread acceptance in the physician community. As an example, for heart disease, we use the models that are published by the Framingham Institute. All the cardiologists, all the physicians are very familiar with the Framingham models. Okay, these are risk models that predict an outcome based on certain risk factors. So once we figure out which disease model we want to use, there is a 3 to 6 to 9 month time frame by the time we can actually take that and operationalize that and bring it to market. And the reason for this is because oftentimes all the data, all the inputs that are needed by these risk models are not always available in the EMR systems, in the medical records of the patients. So in those cases, we have to consult with the specialists, we have to consult with the physicians and figure out what do we need to do? What assumptions do we need to do? How do we fill in those gaps? The other problem that we face a lot of times is just incompleteness, just gaps in the patient data, where you may have a certain set of data for a patient at one point of time and then there may be a huge gap. So what do you do? How do you fill that gap? So there's a whole bunch of assumptions that we need to make. And for that, we've had to consult with physicians over a period of time and perfect those models before we could actually take them to market. And so that's the reason why it has taken us several years of working with the physician community before we are able to develop these library of disease models. The statistical validity of the model is really not a question because these are proven, established models. They are published, they are accepted by the physician community. But oftentimes, our customers want us to actually test the model on their data. They want to test the predictive power of the models on their data. So what we then do is we take the last 3 years of data, we take the first 2 years, we run it through our model, and then we use the output of our model and compare it with what actually happened, how many of the patients were hospitalized. And that gives us a very good sense of the predictive power. It also lets us compare that to the current risk scores and the current risk models that they're using, many of which sometimes are claims-based. Well, historically, the claims-based models were used to do actuarial analysis in order to determine what are the premiums that need to be set on insurance policies. We believe that many of the same models were later repurposed and they are now being used to calculate risk scores. As you know, claims data typically has some clinical information. It has the ICD-9 diagnosis codes, it has the procedure codes, etc. But the most important part, which is the current biometrics, the current biomarkers of the patient are missing. So for example, if a patient has heart disease, in order to really calculate the accurate risk score, you want to know the blood pressure, you want to know the cholesterol levels, the triglyceride levels of the patient. And those data elements are not captured in claims. So the risk scores that are being generated from claims data typically are not as accurate as the ones that are being generated using a combination of claims and EMR, which is basically what we do. So the reason why the EMR-based approach is superior to the claims-based approach is because consistently we have been able to identify early in the disease cycle many more patients using the EMR-based approach than using the claims-based approach. When we compare our results to the claims-based approach and what they have produced, we see a large number of false positives and false negatives. By false positives, I mean those patients that were identified by the claims analysis as being risky, whereas when we actually look at the EMR-based risk and we look at the EMR-based analysis, we find that these patients are actually not risky. And false negatives, where the claims-based analysis actually says that this patient is not risky. And when we run our analysis, we find that this patient is actually risky. And the reason why they said that he was not risky was because there weren't any claims in the last 1 or 2 years. This patient was never hospitalized, never had an emergency room visit, and therefore never came up as a high-cost patient. So the claims analysis is heavily biased towards the patients who had a high cost in the last 1 or 2 years. The EMR-based analysis, on the other hand, gives a much more accurate picture of the patient because there is no bias at all. We don't even consider whether the patient was previously hospitalized or not. So as a result, our risk scores are much more accurate. And when I say much more, I'm saying that we've identified 55%, 60% more patients early in the disease cycle than a traditional claims-based approach.